Hello everyone. So welcome to this recall session of NEET SS 2024 neurology questions. All the questions that I'll be discussing are recalls that I've gathered from my students who have given the exam. So let's get started. Coming to the first question. What is the most likely diagnosis based on the MRI findings given? So this particular MRI axial section was given for the exam. And what were the options? Option A, lissencephaly. Option B, schissencephaly. Option C, holoprosencephaly. And option D, porencephaly. So all the four options were brain malformations. And based on the imaging findings, what do you think is the diagnosis? So when you look at the imaging, okay, please note the arrow as well. Are you all able to appreciate a very smooth brain surface? Number one. Number two, are you all able to appreciate thickened cortex? So based on these two findings, what do you think is the most likely diagnosis? This is most likely to be lissencephaly. So what are the key imaging features in lissencephaly? Let's see. Number one, you've got a smooth brain surface. Number two, thickened cortex. And in some cases, you can get the classic figure of 8 or hourglass appearance on axial imaging, right? Very important points. Let's try to gather a few more important points about the options given in question. Okay, starting with lissencephaly. Key points about lissencephaly. Number one, it is the most common neuronal migration disorder. Okay, right. And what happens in lissencephaly? There is lack of proper differentiation of cortex. Hence, what happens? There is paucity of sulci and gyri formation. Very, very important. And because of this, the brain surface looks very smooth. And remember, lissencephaly is derived from the Greek word lissos, that means smooth, right? There are two important types of lissencephaly. The classic lissencephaly, which is type 1, which is usually due to mutations of LIS1, DCX, or tube A1A gene mutation. And this is your classic lissencephaly with a smooth brain, right? And this classic lissencephaly is a part of the agyria pachygyria spectrum of disorders, right? And then you've got the type 2, also known as cobblestone lissencephaly, wherein you've got an irregular or pebbled surface, right? So this type of lissencephaly occurs as a part of various congenital muscular dystrophies like the Walker-Warburg syndrome as well as the Fukuyama muscular dystrophy as well, right? Some important points you have got to know regarding lissencephaly. A few points regarding schissencephaly, which is also due to defective neuronal migration. And what is the key imaging finding in schissencephaly? You will have a cleft, a gray matter lined cleft, which is extending from the subarachnoid space to the lateral ventricle. So this cleft can be unilateral or bilateral. And there are two important types of schissencephaly. One is the open lip schissencephaly, where you will have wide clefts which are filled with CSF. And you have got the closed lip schissencephaly, where you have got a narrow cleft with fused walls. Okay, want to see the imaging? Let's see it. So you can see two images on your screen. The first one, are you all able to appreciate the cleft which is filled with CSF? This is unilateral as well. So this is the open lip schissencephaly. Clear? No doubts? This is open lip schissencephaly. And see the next image. You're all able to appreciate the cleft, right? Is it unilateral or bilateral? Bilateral. Wide open cleft or fused one? Yeah, this is closed lip schizencephaly. Okay, closed lip schizencephaly. Okay, right. That is also clear. Coming to the next one, holoprosencephaly. What is it? It is the most common malformation of the prosencephalon. And what is the problem here? The cleavage of the forebrain does not occur. And based on the severity, you can divide it into alobar, semilobar, and lobar prosencephaly. Okay, that is based on the severity. Look at this again. Types of holoprosencephaly: lobar, semilobar, and the most severe one, alobar. Okay, where the cleavage is not happening. Okay, you can also see a CT image, and that is actually a semi-lobar holoprosencephaly. Okay, semi-lobar. Okay, so in semi-lobar, there is a partial separation that is happening, and lobar, there is almost complete separation, but not complete. That is lobar prosencephaly, the milder variety. Okay, right. Coming to the next option, which is porencephaly. What is essentially porencephaly? It means there is a CSF filled cavity within the cerebral hemisphere, and this cavity may or may not communicate with the ventricular system. Are you all able to appreciate the cavity? Yes? All right. So that is porencephaly. So after analysis of all these points, I'm sure that you are convinced the answer for this question is option A, lissencephaly. Coming to the next question, a child presents with episodes of head nodding and sudden flexion of the neck and trunk occurring in clusters. Examination and imaging findings are shown. Which drug should be initiated in this patient? So there is a skin finding and there is a contrast enhanced CT finding as well shown. So what is the drug that has to be initiated? What do you think? So child presenting with episodes of head nodding and sudden flexion of neck and trunk occurring in clusters. I am probably considering this to be epileptic spasms. Okay, what am I considering? Epileptic spasms, right? Okay. Uh, Examination findings. Now, if I look at the imaging, what am I seeing? This is probably adenoma sebaceum. This is probably adenoma sebaceum that I am seeing on screen. Yes, adenoma sebaceum. Right. And what is the CT finding? The contrast enhanced CT is being shown. I'm able to see a lesion which is hyperdense, which is close to the lateral ventricle, causing some sort of obstruction and a mild hydrocephalus. So, in the context of a child with epileptic spasms and the skin finding of adenoma sebaceum, this could be a subependymal lesion. And what could be that subependymal lesion? It could be subependymal giant cell astrocytoma. This could be subependymal giant cell astrocytoma, right? So in this patient, my diagnosis will be tuberous sclerosis. Tuberous sclerosis, and the patient is having epileptic spasms. And what drug should be initiated in this patient? Well, I've taught you this. What is the drug to be initiated? It has to be vigabatrin. So we know that epileptic spasms can occur in the context of West syndrome, wherein IV ACTH is the drug of choice. You can also consider prednisolone. But when you have epileptic spasms in the context of tuberous sclerosis, I've always told you the preferred drug to be initiated is vigabatrin. Okay, vigabatrin. So you look at this, vigabatrin, the anti-epileptic, as you all know, is an irreversible inhibitor of GABA transaminase. Okay, Now, if you look at vigabatrin as an anti-epileptic drug, it's a narrow spectrum anti-epileptic drug. So, what is the use of vigabatrin? Mostly as an adjunct, okay, in epilepsies which are not responding to the first line and second line treatments. You can consider it as an adjunct, but remember, there is one FDA approved indication for monotherapy of vigabatrin, and that is in infantile spasms, especially in the context of tuberous sclerosis. So because of that, the answer for this question here will be option A, vigabatrin. Coming to the next question, a child presents with macrocephaly and dystonia. Which enzyme deficiency is the most likely cause? So you can see the MRI finding being shown. Okay, the axial section you can see. The options are isovaleric acidemia, glutaric acidemia type 1, methylmalonic acidemia, and biotinidase deficiency. Mind you, the topic of organic acidemias is very important, and that can be asked, and this is a question based on the topic of organic acidemias. Now, macrocephaly can have so many causes, right? And so is dystonia. But when you have this imaging finding in a patient with macrocephaly and dystonia, are you able to appreciate the widened sylvian fissures resulting in the bat wing appearance? Okay, heard of this? Bat wing appearance due to the widened sylvian fissure. So, what condition is this characteristic of? This is characteristic of the condition that is glutaric acidemia type 1. Okay. So the other options, isovaleric acidemia, would again have basal ganglia involvement. Okay. And if you look at the constellation of clinical presentation with the imaging finding, option B is the right answer. I'm also taking your attention to this particular table in Harrison. You can see that glutaric acidemia type 1 occurs due to an enzyme defect. And what is that enzyme defect? Glutaryl coenzyme A dehydrogenase. And patients can present with severe dystonia and other movement disorders like athetosis, along with motor delays. The other options, isovaleric acidemia, which is which is often uh, asked, and one of the key words that you should be looking for is the sweaty feet order, not mentioned in the question, along with hyperammonemia, biotinidase deficiency, methylmalonic acidemia, all will have metabolic ketoacidosis with its own range of manifestations. And all these disorders are autosomal recessive. But for this particular question, with the clinical presentation and the batwing appearance, answer is option B. Coming to the next question, a neonate presents with seizures, persistent hiccups, and developmental delay. EEG shows burst suppression pattern. What is the most likely diagnosis? Options, holocarboxylase deficiency, arginosuccinic aciduria, isovaleric acidemia, and non-ketotic hyperglycinemia. Well, seizures with developmental delay can occur in umpty number of etiologies. But when you have persistent hiccups as a manifestation and supported by a burst suppression pattern, you should be considering a diagnosis of non-ketotic hyperglycinemia, which is abbreviated as NKH. So, what essentially is non-ketotic hyperglycinemia? This is basically a metabolic disorder, a disorder of glycine metabolism. Okay, and remember, this is better referred to as glycine encephalopathy. So, this is essentially a disorder affecting the mitochondrial glycine cleavage system. And what are the spectrum of manifestations of glycine encephalopathy? So patients present with neonatal encephalopathy with features of lethargy, hypotonia, myoclonic seizures, apnea, and importantly, a burst suppression pattern on EEG with elevated plasma and uh, CSF to plasma glycine. Okay, right. So that is what you should be knowing about this particular disorder. So for this particular question, the answer should be option D, non-ketotic hyperglycinemia. Okay, right. Coming to the next question, identify the investigation shown. Okay, so you can see this image. What are the options? MR angiography, MR elastography, MR spectroscopy, and MR neurography. So what is the image showing you? It's a graph. It's a graph with several peaks, and the diagnosis is simple and straightforward: MR spectroscopy. So what essentially is MR spectroscopy? It is a molecular imaging technique. What does it measure? It measures the level of different chemicals or metabolites inside tissues. So can I say it is essentially a metabolic analysis of the brain tissue? So please understand that the different metabolites that I'm talking about will resonate at different frequencies, which will result in a graphical representation with peaks. Okay, and corresponding to the peak, I'll be able to identify what is the metabolite. So in this graph, the x-axis is corresponding to the chemical shift in ppm, and y-axis correspond to the signal intensity, right? So just to show a few of the major peaks, one is the NAA peak. So NAA is actually the marker of neuronal integrity. So for example, if you have got some sort of neurodegenerative disorders, NAA will be reduced. Choline is marker of cell turnover. So in case of gliomas, you can have elevated choline peak. And similarly, you have got other peaks like lipid, lactate, myoinositol. So different peaks, and each of which would confer a meaning to it, right? So for this question, the answer is going to be MR spectroscopy. Look at the other options. Option A, MR angiography, which is nothing but a vessel imaging. MR elastography is used to assess the tissue stiffness, maybe in case of liver cirrhosis. MR neurography is one investigation wherein it's a high resolution MR imaging of the peripheral nerves. For this question, answer is going to be option C, MR spectroscopy. Which of the following thrombophilic disorders is most strongly associated with increased risk of ischemic stroke? So all the four options that have been given: antiphospholipid antibody syndrome, antithrombin 3 deficiency, factor 5 Leiden mutation, and protein S deficiency, all the four are hypercoagulable state. The first option is an acquired hypercoagulable state. The remaining options are inherited hypercoagulable states. So which do you think is most strongly associated with increased risk of ischemic stroke? It is antiphospholipid antibody syndrome. Look, the remaining three options do confer an increased risk of thrombosis, but mostly it is venous thrombosis, predisposing to cerebral venous thrombosis. Okay, whereas antiphospholipid antibody syndrome can predispose to both arterial and venous thrombosis. For this question, answer is going to be option A. A female patient diagnosed with multiple sclerosis has low JC virus titers and desires pregnancy in future. Which disease modifying therapy is most appropriate to start? What are the options? Fingolimod, interferon beta, natalizumab and teriflunomide. Now, disease-modifying therapy in multiple sclerosis is a high topic both for NEET SS and INISS. Okay, and I've told my students to be very thorough with it. Now, this particular question is based on the management again of multiple sclerosis, this time related to pregnancy. So we have got a female, she's diagnosed with MS and there is low JC virus titer. Okay, and in future she is planning pregnancy. Now, what is the most appropriate one? Is it fingolimod, interferon beta, natalizumab, teriflunomide? Now, you should make a decision considering pregnancy also. Okay, that is what is important. Now, I think this particular, flowchart that you are seeing is very, very important and will help you making decisions related to such questions. Okay, now teriflunomide, which is given in option, is highly teratogenic as you can see. So there is absolutely no way that you are considering teriflunomide. Okay, and what about fingolimod? You can see that fingolimod also has weak teratogenic effect. Okay, so that is one problem with fingolimod. So that also is not a favored drug when you consider pregnancy. Coming to interferon beta and natalizumab. Now, if the question had made a mention of high JC virus titers, then since there is a high risk of developing progressive multifocal leukoencephalopathy, I would not have considered natalizumab. But here, there is a specific mention that it is low JC virus titer, which means the chance of developing PML is relatively less. But still, if you look at this, you can see that in case of natalizumab, okay, one problem is you can have infant pancytopenia, especially with late pregnancy exposure. And along with that, one problem with both fingolimod and natalizumab is there is a high risk of rebound disease activity 8 to 6 weeks post cessation. So the guidelines also recommend that if anyone is already on fingolimod or natalizumab, switch to rituximab or ocrelizumab before discontinuing contraception. That is what the guideline tells you. Now, considering that fact, natalizumab is also not a preferred choice. Interferon beta, as you can see, well, it is definitely safe. So for this question, interferon beta is the best answer here. Interferon beta, right? Okay. And some students told me that, sir, in the option, it was not interferon beta. I think it was interferon gamma. Well, in that case, maybe you can consider natalizumab as the answer. But if I'm taking recall in this way, the answer has to be interferon beta. Okay, that's what I want to tell you. Option B is the answer. A very simple, straightforward question. A patient presents with unilateral pulsating headache, photophobia, phonophobia, and osmophobia. Which of the following is the most likely diagnosis? Now, considering a unilateral headache of pulsating nature, along with associated features like photophobia, okay, light again triggering the headache, phonophobia, sound triggering headache, osmophobia, certain odors triggering headache. This is the classic description of migraine. I'm not considering any of the trigeminal autonomic cephalalgias, which are option A, B, C, because I have not got any definite feature of autonomic symptoms. I'm not seeing any feature suggestive of trigeminal autonomic cephalalgias. Hence, the best answer is option D, migraine. And I also want to tell all my dear students, this particular table in Harrison is very important for your exams. You may get another question maybe in the upcoming exams based on TAC or maybe migraine, tension type headache, trigeminal neuralgia, post-herpetic neuralgia. So all these are high yield topics for NEET SS and INISS. Okay, right. A 45-year-old woman a known case of rheumatoid arthritis for the past 10 years. So, long standing rheumatoid arthritis. Patient presents with complaints of numbness and paresthesias in both lower limbs for the past few weeks. She also has non-healing ulcers over the lower extremities and absent ankle reflexes on examination. She is on regular treatment for rheumatoid arthritis. What is the most likely diagnosis? Is it rheumatoid arthritis associated vasculitis? Is it drug-induced peripheral neuropathy? Is it rheumatoid myelopathy or is it amyloid neuropathy? So what is the patient presenting with? You can see that patient has got some sensory symptoms, numbness and paresthesias. Okay. And this mostly suggests the patient has got some sort of a peripheral neuropathy. That is what I want to tell you, right? And if you look at the options, I'm not considering a myelopathy. So I'm not getting any features of a UMN lesion. You can see the patient is having absent ankle reflexes, right? So I'm not considering a UMN lesion here. So maybe an atlantoaxial subluxation resulting in a rheumatoid myelopathy is not in my consideration for this question. Could it be drug-induced peripheral neuropathy? Well, out of the drugs that you give for rheumatoid arthritis, none of them are well known to cause this sort of a peripheral neuropathy with non-healing ulcers. Hence, I am eliminating that option. Now it is between rheumatoid arthritis associated vasculitis and amyloid neuropathy. What do you think? So let's dive into a few more details regarding RA associated vasculitis and amyloid neuropathy before coming to a conclusion. Okay. So regarding rheumatoid vasculitis, you can see that Bradley is mentioning rheumatoid vasculitis is the second most frequently identified cause of vasculitic neuropathy, and it can have different patterns. You can have mononeuropathy, mononeuritis multiplex, and a distal symmetric sensory motor polyneuropathy as given in question. Okay, so that rheumatoid vasculitis is well known to have this sort of a presentation. Now, when you look at the amyloid neuropathy, because look, in rheumatoid arthritis, long standing, you can have AL amyloidosis uh, resulting in amyloid neuropathy. But one point I want to tell you is that in amyloid neuropathy, one point is you are going to have prominent autonomic features. That is what I've highlighted. So patients will be having significant features of autonomic dysfunction which can manifest as GI motility disorders like early satiety, diarrhea, or sometimes constipation, dry eyes, dry mouth, impotence, orthostatic hypotension, neurogenic bladder. But there is no reference to any of autonomic manifestations here. And also, ulcers are less likely to occur in amyloid neuropathy in comparison to RA associated vasculitic neuropathy. And because of these two features, I am going to diagnose this as most probably an RA associated vasculitis. Option A will be my answer. A patient with history of intestinal resection presents with progressive ataxia and loss of proprioception. Which of the following vitamin deficiencies is most likely to cause these neurological symptoms? So definitely there has to be a link between intestinal resection and the symptoms of the patient, that is progressive ataxia and loss of proprioception. So what vitamin deficiency is this likely to be? All the options are fat soluble vitamins A, D, E, K. What do you think is the answer? Well, this presentation, that is the context of an intestinal resection and the manifestations, most likely is favoring vitamin E deficiency. Let me substantiate. Look at this from Harrison. So, what are the contexts in which you can expect a vitamin E deficiency? So, vitamin E deficiency is seen only in severe and prolonged malabsorptive disorders like celiac disease, chronic cholestatic liver disease, after small intestinal resection or bariatric surgery. That is the context. What about the manifestation? So vitamin E deficiency can lead on to axonal degeneration, of the large myelinated axons, and this would result in damage to posterior column number 1 and spinocerebellar tract as well. So you can have even peripheral neuropathy features, right? So characterized by areflexia, progression to an ataxic gait, decreased vibration and position sense as well. Ophthalmoplegia, skeletal myopathy and pigmented retinopathy may also be features of vitamin E deficiency. So coming to this question, can there be progressive ataxia? Yes. Can you have loss of proprioception? Absolutely yes. Answer is going to be option C, vitamin E. A patient with HIV on antiretroviral therapy, including stavudine, presents with burning pain and numbness in a glove and stocking distribution, along with absent ankle reflexes. Laboratory studies shows elevated serum lactate levels. What is the most likely diagnosis? Look at the options. Stavudine induced toxic neuropathy, HIV associated distal sensory polyneuropathy, HIV associated vacuolar myelopathy, and HIV related inflammatory myelopathy. So, patient has retroviral infection. Patient is on antiretroviral therapy. There is a specific mention that the ART in this patient includes stavudine, and the clinical presentation is with pain and numbness in glove and stocking distribution, along with absent ankle reflexes. This is basically suggestive of a peripheral neuropathy, right? So if you look at the options, I'm already eliminating myelopathy, no UMN features. You can see absent ankle reflexes. And this is neuropathy. It's not a myopathy. You can see, sensory features as well. HIV related myopathy is not my consideration. Now, could this be a stavudine induced toxic neuropathy, or could it be HIV associated distal sensory polyneuropathy? What do you think? I think the most important point here is serum lactate levels, which are elevated, because stavudine can cause some mitochondrial damage, and because of which the lactate levels are likely to be elevated in patients with stavudine induced toxic neuropathy. So you've got to understand, though retroviral infections can also have a similar sort of presentation, since the serum lactate levels are elevated, that would be my preference. So you can see this particular Bradley neurology screenshot, again showing you stavudine related to neuropathy along with lactic acidosis. So for this question, my answer is going to be option A, stavudine induced toxic neuropathy. Coming to the next question, well, this was a scenario of a patient who had memory loss along with some features of subacute combined degeneration of the spinal cord was mentioned, and they had asked what is the diagnosis. I got only a partial recall from the students, but this is a simple straightforward case of vitamin B12 deficiency. Next question on the side effect of oxcarbazepine. I've always told students to learn anti-epileptics in detail for both NEET SS and INISS. So regarding oxcarbazepine, you all know that it is a structural analog of carbamazepine, but with minor structural differences that would result in major differences in metabolism and induction of metabolic pathways, right? Coming to the side effect profile of oxcarbazepine, well, it can cause certain side effects like drowsiness, headache, fatigue, and higher doses Just like carbamazepine, it can result in dizziness, blurred vision, diplopia, nausea, vomiting, and ataxia. You can have rash also. But importantly, the point that you've got to note is that oxcarbazepine is more likely to cause hyponatremia than carbamazepine. This is very, very important. And such sort of symptomatic hyponatremia is more likely to occur in older individuals and those taking diuretic. So for this question, I have not got the full recall. Answer is option A, hyponatremia. A 60-year-old male presents with fever, headache, and neck stiffness, along with altered sensorium of 5 days duration. CSF analysis is suggestive of neutrophilic pleocytosis. What is the most appropriate initial antibiotic regimen for this patient? So the classic triad of meningitis is here: fever, headache, and neck stiffness. And this looks slightly complicated as the patient is also having altered sensorium. So since it is a short duration illness, 5 days, with CSF suggestive of neutrophilic pleocytosis, this is most likely an acute bacterial meningitis. This is most likely an acute bacterial meningitis. Okay. And the question is regarding the most appropriate antibiotic regimen. You've also got to consider the age of the patient, 60 years. Now, in a patient of this age group, what are the possible organisms that can cause meningitis? Number one, pneumococcus. Number two, Neisseria meningitidis. And number three, especially because the age is, in this range, especially above 55 years, you've also got to consider Listeria monocytogenes. Okay, very important. So these organisms must be covered in the antibiotic regimen. So if you look at the options, all the options, ceftriaxone is there. So third generation cephalosporin will definitely help, especially dealing with an organism like pneumococcus. Yes, ceftriaxone is going to help. But will monotherapy with ceftriaxone help? No, because you need to add vancomycin as well. Why vancomycin? You can have pneumococci that are resistant to beta-lactam. So there has to be vancomycin as well in the regimen. So option A is eliminated. Option D also does not have vancomycin eliminated. So do you think these two antibiotics alone might suffice? This is where again you have got to look at the age. Since Listeria monocytogenes is also in strong consideration, you need an antibiotic that can deal with it as well. But ceftriaxone and vancomycin, both of them are not very effective against Listeria monocytogenes, but ampicillin is. So you will have to give a triple drug therapy consisting of ceftriaxone, vancomycin, as well as ampicillin. Option C will be the best answer for this question. And I also want my students to go through this simple table in Harrison, which again shows that any adult with age more than 55 years and adults of any age with alcoholism or other debilitating illnesses, you give ampicillin plus a third generation or fourth generation cephalosporin with vancomycin. This combination will be the answer for this question. Option C is the answer. A child presents with chronic progressive ataxia. Ocular examination reveals conjunctival telangiectasia. MRI findings are shown. What is the most likely diagnosis? So what is the clinical presentation? Chronic progressive ataxia in a child, which suggests that it is probably some sort of neurodegeneration. Yes, the examination finding is conjunctival telangiectasia. Some students told me that image also was provided of the conjunctival telangiectasia. Okay, and MRI findings. Students told me there were two MRI findings given. The number one was a definite cerebellar atrophy, is what the students told me. So there was definite cerebellar atrophy. Okay, definite cerebellar atrophy was there. And the next image was susceptibility weighted imaging, that is SWI, and the students told me there were multiple hypointensities. So SWI showing hypointensities. Okay, right. So what do you think is the most likely diagnosis? Is it cavernous angioma, cerebral telangiectasia, FAR syndrome, or is it neurodegeneration with brain iron accumulation? Well, in a child with chronic progressive ataxia, telangiectasia, I'm sure that all of you would have been tempted to think about ataxia, telangiectasia. So was I, but no direct mention of ataxia, telangiectasia was given in the options, right? So let's try to look at the options. Number one, cavernous angioma. See, cavernous angioma is not going to have this sort of a clinical presentation of a chronic progressive ataxia, telangiectasia. It will show some sort of popcorn appearance in the imaging, but not any sort of significant cerebellar atrophy. So that is not matching. Okay, it's not going to be angioma. Cerebral telangiectasia. Please understand, in ataxia telangiectasia, you can have telangiectatic vessels in the brain which are fragile, and these vessels can rupture, which can result in microbleeds. You can have hypointensities in susceptibility weighted imaging, definitely possible. So there is a good chance that cerebral telangiectasias, they are referring to that seen in ataxia telangiectasia, considering the spectrum. So this is one strong possibility that I would consider. But just to look at the other options, FAR syndrome. FAR syndrome can present with movement disorders, but mostly it will be basal ganglia and cerebellar calcification. You're not going to get this sort of atrophy and all. Okay, so that is not in my consideration. Neurodegeneration with brain iron accumulation. Again, the profile is not matching. Chronic progressive ataxia, telangiectasia, that is not the presentation of NBIA. So that is also not in my consideration. So among the options, the best is cerebral telangiectasia, mostly in the context of ataxia telangiectasia. Option B will be the answer for this question. So that's it. We have had a discussion of the NEET SS 2024 neurology questions. Hope you liked it. Thank you so much.